Welcome back to the Deep Dive, where we unpack complex topics and make them incredibly accessible, insightful, and, dare I say, truly captivating. Today we're plunging into the remarkable world of the liver, an organ so vital, so dynamic, and so central to our very existence that ancient civilizations built myths around its incredible abilities. Remember Prometheus, whose liver regenerated daily after being devoured? Well, it turns out there's a profound truth to that ancient folklore. And that's just the tip of the iceberg of what we now understand. You, our listener, have asked us to go incredibly deep, to master this information as if you're preparing to become an elite professional in the field, extracting every important nugget of knowledge from the sources you've provided. And that's exactly what we're going to do. We'll be your expert guides, offering the ultimate shortcut to being not just informed, but truly fluent in the intricate language of the liver.
Indeed, the liver is an absolute powerhouse, performing a diverse spectrum of functions absolutely essential for life. Our mission today is to connect the dots, offering you not just the what of liver anatomy, physiology, and disease, but critically, the why it matters, providing the broader context and profound implications of liver health and disease for the entire body. From its most microscopic cellular signaling pathways to the macro-level precision of modern surgical techniques, we're going to explore every facet covered in your sources. We want to ensure you gain a truly professional-level understanding of this vital organ.
All right, let's unpack this incredible organ, starting with its fascinating journey through history and then delving into its intricate, almost bewildering structure. It's truly amazing how much our understanding of the liver has evolved from ancient wisdom to today's cutting-edge science.
It really is. And what's fascinating is how far back humanity recognized the liver's unique properties. That ancient Greek myth of Prometheus, where his liver regenerated daily after being eaten by an eagle, it wasn't just folklore. The Greek word for liver, apar, it actually means mend or repair.
Wow.
They were onto something incredibly profound. Even further back, around 2000 BC, the Babylonians considered it the seat of the soul.
The soul.
Yeah, underscoring just how vital and mysterious this organ was perceived to be. For millennia, actually operating on this highly vascular organ was considered almost impossible, often fraught with fatal peril due to unstoppable bleeding.
Right, the bleeding must have been terrifying.
Exactly. So it's quite remarkable that the first recorded elective hepatic resection, a planned surgical removal, only occurred surprisingly recently, in 1888. In Germany.
1888, that late.
Yes. And within just over a decade, surgeons were already publishing series of resections, marking significant, albeit cautious, early progress.
So what does this all mean for modern surgery? It sounds like despite these early efforts, there was still a long, almost half-century pause before major advancements really took hold. Was the challenge of massive hemorrhage, even with techniques like the Pringle maneuver that emerged later, just too overwhelming?
Precisely. You hit on a key point there. Very little significant progress in surgical techniques was recorded for the next half-century, largely because controlling that massive bleeding remained an overwhelming obstacle. The Pringle maneuver, described in 1908, where surgeons temporarily compressed the porta hepatis.
That's the main highway of blood vessels into the liver.
Exactly. The main inflow tract to control bleeding was an ingenious early innovation. But it was only in the 1950s that a transformative period began. Seminal contributions by pioneering researchers and surgeons, notably Rex, Cantley, Kuno, and Starzl. They laid the foundational groundwork for the precise, safer science we see today. Their work fundamentally changed how we approach liver surgery, making it far more effective.
Now, here's where it gets really interesting for understanding how surgeons navigate this organ. The liver is the largest gland in the body, weighing about 1,200–1,500 grams, typically reddish-brown, and largely protected by the rib cage, encased in a fibrous sheath called Glisson's capsule. But it's clearly not just a simple blob, right? It's held by specific ligaments and has distinct regions, which are absolutely critical for any surgical planning.
Absolutely. Understanding these foundational anatomical landmarks is essential for any professional dealing with the liver. It's secured by several ligaments, many of which can be safely divided in a bloodless plane to facilitate resection, essentially freeing the liver for access. For example, the round ligament, that's a remnant of the umbilical vein. The falciform ligament anchors the liver to the anterior abdominal wall and separates what we call the left lateral and left medial segments. Deep inside, the ligamentum venosum is another fibrous remnant. On the sides, the left and right triangular ligaments secure the liver to the diaphragm.
So it's really anchored in place.
Very securely. More centrally, The hepatoduodenal and gastrohepatic ligaments attach the liver to the digestive system. The hepatoduodenal ligament is particularly crucial, often called the porta hepatis, as it bundles together the common bile duct, the hepatic artery, and the portal vein.
The big three.
The liver's main inflow and outflow structures, exactly. And for critical vascular control during surgery, a passage behind the porta hepatis, the foramen of Winslow, allows for clamping the entire blood supply.
The Pringle maneuver again.
Precisely.
This is where the aha moment happens for many trying to visualize liver surgery. It's not just big generic lobes, but these detailed segments that act as a surgeon's precise roadmap.
Indeed. While we talk about gross separation into right and left lobes, roughly 60–70% of the mass in the right lobe, that's just a starting point. The real game changer came from the detailed work of the French surgeon Cuneau in the 1950s. He revolutionized our approach by dividing the liver into 8 anatomically and functionally distinct segments, numbered clockwise.
Clockwise, okay.
So what we call the anatomical left lobe includes segments 2, 3, and 4. Segments 2 and 3 form the left lateral segment, and segment 4 is the left medial segment. The right lobe then consists of segments V, 6, 7, and 8.
Got it.
This segmental understanding is paramount because it allows surgeons to remove diseased portions while preserving the remaining healthy segments, ensuring sufficient functional liver volume. Further refinements, like the Brisbane 2000 terminology, have created a universal language for these segments, greatly improving communication in the surgical world.
So the liver gets blood from 2 main sources. Why is that dual blood supply so significant, and how does it affect surgery, especially with all these surprising variations?
This dual blood supply, roughly 25% from the hepatic artery and a remarkable 75% from the portal vein, is fundamental. It means the liver is incredibly resilient, often able to withstand significant injury. But it also presents unique challenges for surgeons because the blood vessel anatomy is remarkably variable.
Variable? How variable?
Deviating from the textbook in nearly a quarter of individual.
Wow, 25%.
Yes. For surgeons, recognizing these deviations before surgery via advanced imaging and then confirming them by careful palpation during the procedure, even feeling for a subtle pulsation where it shouldn't be, that is absolutely critical to avoid potentially devastating complications. The hepatic artery, a branch of the celiac axis, typically divides into right and left hepatic arteries. But a common variation, for example, is an accessory right hepatic artery coming off a completely different vessel, the superior mesenteric artery.
That's a huge variation, and that's just one example.
Just one. There are others, like a replaced left hepatic artery from the left gastric. Up to 24% have some kind of arterial variant.
That's a lot of variability in the arterial supply.
Yeah.
What about the portal vein, the other major blood supply, carrying that crucial 75% of the blood from the gut?
The portal vein is a true superhighway. It's formed by the confluence of the splenic and superior mesenteric veins. And it carries all the splanchnic blood rich in absorbed nutrients and sometimes toxins from most of your digestive organs, spleen, and pancreas directly to the liver.
So it's the first stop for everything we absorb.
Exactly. This makes the liver the body's first processing center for everything entering your bloodstream from the gut. The portal vein is unique because it's valveless, meaning blood flows solely based on pressure gradients. While normal pressure is low, in conditions like cirrhosis, resistance within the liver dramatically increases pressure in this valveless system.
Leading to problem.
Big problems. This forces blood to shunt into systemic circulation through collateral vessels, most notably at the gastroesophageal junction, leading to dilated, fragile veins called varices, which carry a very high risk of life-threatening hemorrhage. Surgeons must be incredibly vigilant for these intricate, variable branching patterns too. Aberrant portal venous anatomy is present in 20–35% of people.
So we have blood coming in. How does it leave? And how does bile, that critical digestive fluid, get out? It sounds like there's a lot of interconnectedness here, both in terms of blood and bile flow.
Right. The outflow of blood from the liver is managed by 3 major hepatic veins, the right, middle, and left, which drain directly into the suprahepatic inferior vena cava, or IVC, eventually leading to the heart. The caudate lobe, segment I, is unique. It often drains directly into the IVC, independent of the other 3.
Okay.
This drainage pattern is crucial for surgeons to understand, as damaging these veins can lead to significant blood loss. There can also be accessory veins, like an inferior right hepatic vein in 15–20% of cases, which is a major bleeding risk during a right hepatectomy.
And the bile drainage.
For bile drainage. The common bile duct, which leads to the gallbladder, ultimately forms from the right and left hepatic ducts inside the liver. These ducts follow a branching pattern similar to the arteries. However, here's another critical area of variability. Accessory or non-standard bile duct confluences are common.
How common?
In 30–40% of people.
That high?
Yes. Recognizing these variations preoperatively and during surgery is vital to avoid devastating bile duct injuries or leaks, which can lead to severe postoperative complications. The gallbladder itself, where bile is stored and concentrated, sits adhered to segments IVB and V of the liver.
Are there nerves and lymphatics in the liver, and what role do they play, even if their functions seem subtle compared to the major blood and bile pathways?
Yes, absolutely, though their functions are still being fully understood. The liver receives both parasympathetic innervation from the vagus nerves and sympathetic innervation from the splanchnic nerves and celiac ganglia. Interestingly, a transplanted denervated liver functions normally, suggesting their continuous signaling isn't strictly essential for the liver's fundamental metabolic operations.
So what's the point of the nerves then?
Well, a clinically important point is referred pain. When the liver's fibrous capsule, Glisson's capsule, is stretched or the diaphragm is irritated, the pain can be felt in the right shoulder and scapula, transmitted by the right phrenic nerve. This is a key diagnostic clue for clinicians.
Oh, okay. And the lymphatics?
Regarding lymphatic drainage, lymph is produced within the liver, draining from tiny spaces like the space of Disse to larger lymphatics. Eventually, it reaches nodes around the porta hepatis and extending up towards the diaphragm. This extensive lymphatic network is particularly important in the context of cancer.
Why is that?
It's a common pathway for the spread of malignancies like cholangiocarcinoma, which often metastasizes to these regional lymph nodes. Recognizing these nodes on imaging provides vital clues for cancer staging.
Now that we've mapped out the liver's intricate structure, let's dive into its truly incredible functions. This is where you really appreciate why it's called a powerhouse. It's a multitasking marvel, central to so many of our body's systems.
You're absolutely right. The liver is the body's largest gland, performing an extraordinary array of functions including storage, metabolism, production, and secretion. It's absolutely central to processing all absorbed nutrients from the gastrointestinal tract.
Like what specific?
For instance, in carbohydrate metabolism, the liver is the master regulator of glucose. In a fasting state, it ensures your brain gets a continuous supply of glucose through glycogenolysis, breaking down stored glycogen, and gluconeogenesis, making new glucose from non-carbohydrate sources like lactate or amino acids.
And after eating?
After a meal, it removes excess glucose, either storing it as glycogen or converting it into fats through lipogenesis. In lipid metabolism, it's key for forming bile and producing essential cholesterol and fatty acids. And when it comes to protein metabolism, the liver deaminates amino acids, producing ammonia, which then detoxifies into urea for safe excretion. Critically, it synthesizes most circulating plasma proteins, including albumin, and almost all factors necessary for blood coagulation and fibrinolysis.
So thinking ahead, if liver function declines significantly, how might these vital processes be affected? What are the wider systemic consequences for the whole body?
That's exactly the critical question. If synthesis falters, you see low albumin causing fluid shifts and swelling. Impaired clotting factor production leads to easy bruising and potentially life-threatening bleeding. Energy metabolism gets disrupted. It really impacts almost every system.
So the liver is like the body's super efficient waste disposal and chemical transformation plant, especially for drugs and toxins.
Oh.
How does it handle all those foreign molecules and make them safe for excretion?
This is a core function, absolutely vital for understanding pharmacology and toxicology. The liver transforms lipophilic or fat-soluble drugs and foreign substances into more hydrophilic, water-soluble products for excretion, primarily through two phases. Phase 1 reactions involve processes like oxidation, often by the famous cytochrome P450 system, making metabolites more reactive.
Okay, phase 1 makes them reactive.
Exactly. Then phase 2 reactions, or conjugation, involve adding larger water-soluble groups to tag the molecule for excretion via bile or urine. This transformation process is highly variable among individuals, influenced by genetics, diet, other medications.
Making drug responses unpredictable sometimes.
Highly unpredictable. Increased metabolism shortens drug action, decreased metabolism prolongs it. Acetaminophen, or paracetamol, is a classic and critical example. Normally, it's safely conjugated into harmless metabolites, but in an overdose, these normal pathways get overwhelmed.
And then?
The cytochrome P450 system produces a toxic intermediate, Normally, your body's natural antioxidant glutathione detoxifies this. But when glutathione stores are depleted by the sheer volume of toxin, this intermediate attacks liver cells, causing widespread necrosis or cell death.
Which is why the antidote works.
Precisely. N-acetylcysteine, or NAC, works by replenishing those glutathione stores. It highlights the liver's critical, yet sometimes fragile, role in drug safety.
Speaking of waste, bilirubin is a common term we hear in blood tests. What exactly is it, and how does the liver process it into bile, which is also a critical digestive fluid?
Bilirubin is essentially a breakdown product of heme, primarily from old red blood cells. This initial bilirubin is unconjugated and insoluble in water, so it travels to the liver bound to albumin. Inside the liver, it undergoes a crucial transformation. It's conjugated to glucuronic acid by an enzyme called glucuronal transferase.
Making it water-soluble.
Exactly. Once water-soluble, it's actively excreted into tiny channels called bile canaliculi, which eventually form the bile ducts. Most of this conjugated bilirubin is then excreted in feces, giving it its characteristic color. However, some is reabsorbed from the intestine and either re-excreted by the liver or eliminated in urine. This efficient recycling of bile salts and bilirubin between the liver and intestine is called the enterohepatic circulation.
Enterohepatic circulation, okay.
Where an impressive 90–95% of bile salts are reabsorbed in the terminal ileum, ensuring they are not wasted. It's incredibly efficient.
And bile itself, what's its role?
Bile itself is a complex, alkaline fluid produced continuously by hepatocytes about 1 liter daily. It's stored and concentrated in the gallbladder between meals and released into the duodenum when you eat fat. Bile has 2 fundamental roles. First, it aids in the digestion and absorption of fats and fat-soluble vitamins by emulsifying them, like detergent on grease. Second, it serves as a crucial route for eliminating waste products like bilirubin and excess cholesterol from the body via feces. Bile salts, derived from cholesterol, are the key components responsible for fat digestion. This whole system is a remarkably efficient and vital part of our digestive and detoxification processes.
Everyone's heard of liver function tests, but you mentioned that term can be misleading. So what are these tests actually telling us when a doctor orders them, and what's the professional secret to interpreting them correctly?
This is a key point for any professional to grasp, because the term liver function tests, or LFTs, is in fact a common misnomer. Most commonly measured markers like AST, ALT, AP, GGT, and total bilirubin, they primarily indicate liver cell damage or cholestasis.
Cholestasis being impaired bile flow.
Correct. Impaired bile flow. They don't necessarily reflect the liver's overall synthetic function. The liver has such a tremendous reserve capacity that true synthetic function can be maintained even with significant damage.
Okay, so what do AST and ALT tell us then?
When we see elevated AST and ALT, these enzymes, called aminotransferases, signal hepatocellular injury liver cell damage. ALT is more liver-specific than AST, which is also found in heart, muscle, and other tissues. The pattern and magnitude of elevation offer clues. An AST-ALT ratio greater than 2.1 is common in alcoholic liver disease. Mild elevations might point to fatty liver, while levels in the thousands suggest acute severe damage like ischemic insult or an overdose.
But there's a catch.
Here's the professional nuance. These levels correlate poorly with the severity of damage in advanced fibrosis or cirrhosis, because the remaining functional cells may not be releasing large amounts of enzymes even if the overall liver is badly scarred.
So how do we assess actual liver function?
To truly assess abnormal synthetic function, we look at different markers: serum albumin levels and prothrombin time, PT International Normalized Ratio, INR. Albumin has a long half-life, about 20 days, so it's not an acute marker, but chronically low levels suggest impaired synthesis over time. PT and INR are excellent and more immediate indicators, as most clotting factors, except factor VIII, are synthesized exclusively in the liver.
Making them a direct readout of liver production.
Exactly. A prolonged PT-INR, especially one that doesn't correct with vitamin K administration, is a much stronger indicator of true liver failure.
Okay, and the third category was cholestasis.
Right. Cholestasis, or impaired bile flow, is indicated by elevated bilirubin, alkaline phosphatase, AP, and gamma-glutamyl transpeptidase, GGT. Bilirubin fractionation distinguishing between unconjugated, indirect, and conjugated, direct, is crucial here. Elevated unconjugated bilirubin suggests issues before the liver processes it, like hemolytic anemia. Elevated conjugated bilirubin points to problems within the liver's excretion pathways or an obstruction in the bile ducts downstream.
So the type of bilirubin tells you where the problem likely is.
Precisely. Conjugated bilirubin is water-soluble, so it can spill into the urine, making it dark. AP and GGT are enzymes from the bile duct lining. They rise with biliary obstruction. GGT is less specific, but when elevated alongside AP, strongly suggests a liver or biliary source. So it's less about a simple liver function test and more about deciphering a complex array of signals to pinpoint the exact nature and location of the problem.
Jaundice, that dramatic yellowish discoloration of the skin and eyes, is such a clear visual warning sign. It sounds like it can be caused by problems at virtually any stage of bilirubin processing, from its initial production to its final excretion.
Exactly. Jaundice becomes clinically detectable when bilirubin levels exceed about 2.5 to 3 milligdl, and its presence always warrants a systematic professional workup. We categorize the causes based on where the bilirubin metabolism process goes awry: pre-hepatic, intrahepatic, or post-hepatic.
Before, within, or after the liver.
Correct. Pre-hepatic jaundice occurs before the bilirubin even reaches the liver for processing. This is typically due to excessive production of unconjugated bilirubin, usually from conditions causing increased heme metabolism, overwhelming the liver's conjugation capacity. The most common culprits are hemolytic anemias, where red blood cells are broken down too quickly.
Okay, then intrahepatic.
Intrahepatic jaundice involves problems within the hepatocytes themselves, affecting their ability to conjugate bilirubin or excrete bile. This can stem from impaired hepatic blood flow, like in shock, or from inherited enzyme disorders like Gilbert's syndrome.
Which is quite common and usually benign, right?
Yes, very common, often just transient jaundice under stress. Or more severe, rare genetic disorders like Crigler-Najjar. Many acquired conditions like viral hepatitis, alcohol abuse, sepsis, autoimmune disorders, and various medications can also cause intrahepatic cholestasis by disrupting bilirubin transport within the liver cells.
And finally, postcopatic.
Posthepatic jaundice results from an obstruction of the biliary duct system, physically preventing the flow of conjugated bile into the duodenum. This is often the type of jaundice that presents with direct or conjugated hyperbilirubinemia, pale stools, and dark urine. Common causes include intrinsic biliary diseases like gallstones blocking the common bile duct, choledochylithiasis, strictures, cholangiocarcinoma, or cholangitis. Extrinsic compression of the biliary tree is also frequent, often due to pancreatic disorders like pancreatitis or pancreatic cancer pressing on the bile duct.
So jaundice is really a symptom with many potential underlying causes.
Absolutely. It's a critical sign that demands thorough investigation.
The liver isn't just about metabolism, it's also a major player in our body's defense system. Given its unique position receiving blood from the gut, how does it react to threats like inflammation and infection at a molecular level, acting as a crucial first responder?
This is a key area of research for understanding systemic responses, as the liver acts as a central regulator of our overall inflammatory response. One primary way it participates is through the acute phase reaction. This involves the rapid synthesis and release of acute phase proteins into the circulation in response to inflammation anywhere in the body.
Triggered by signals from the site of injury.
Exactly. This synthesis is driven by powerful inflammatory cytokines, chemical messengers like TNF-A, IL-1, and IL-6 released by inflammatory cells at injury sites. The liver responds by significantly increasing its synthesis of proteins like C-reactive protein, CRP, complement factors, and alpha-1 antitrypsin. Interestingly, some proteins like albumin and transferrin actually decrease. They're called negative acute phase proteins.
And the purpose of these proteins?
The purpose is multifaceted: to contain infections, prevent further tissue damage, and initiate repair and regeneration. For example, CRP helps clear microorganisms by binding to them, and complement helps phagocytosis. Alpha-1 antitrypsin inhibits damaging enzymes released by our own inflammatory cells. So these liver-produced proteins serve as an early, crucial defense mechanism, preparing the body even before the full activation of the adaptive immune system.
It makes perfect sense that the liver is heavily involved in immune surveillance, given it receives all that blood drainage directly from the gastrointestinal tract, a prime source of bacteria. But how does it specifically deal with bacterial toxins like LPS, which are notorious for causing septic shock?
You've hit on a crucial point about the liver's strategic position. It truly acts as the final barrier preventing bacteria and their potent toxins, especially from the gut, from reaching systemic circulation. Gram-negative bacterial infections produce endotoxin, or lipopolysaccharide, LPS, a potent glycolipid. Even in tiny amounts, its lipid component can trigger septic shock and multi-organ failure, largely by causing an excessive release of inflammatory cytokines.
So how does the liver neutralize this LPS?
The liver handles LPS through a complex molecular dance involving several key mediators. First, lipopolysaccharide binding protein, LBP, itself an acute phase protein from hepatocytes, binds to LPS. This complex then interacts with CD14, a receptor found on immune cells like macrophages, but also soluble in the blood. But for the signal to be transmitted into the cell, it requires the crucial toll-like receptor 4, TLR4, and an accessory protein called MD2.
TLR4, we'll come back to those later.
Yes, TLR4 is the direct molecular sensor for bacterial LPS. Its activation by this LBP LPS CD14 MD2 complex transmits a signal into the cell via distinct pathways, triggering that profound inflammatory response we see in sepsis. Kupffer cells, the liver's resident macrophages, are key players, clearing most LPS and producing these cytokines. But hepatocytes also participate. Understanding this pathway is absolutely paramount for developing effective strategies to combat sepsis and even specific liver disorders like alcohol-induced liver disease, where gut-derived LPS plays a role.
Nitric oxide, or NO, is well known for its role in regulating blood vessels, but it also has a significant and seemingly contradictory role in the liver. How can one simple molecule be both protective and harmful depending on the context?
This raises an important question. How can such a simple molecule have such complex effects? It's fascinating. N is a diffusible free radical gas produced by three main enzymes or syntheses: neuronal NOS, NS, endothelial NOS, eNOS, and inducible or inflammatory NOS, aNOS. NOS and eNOS are always present, constitutively expressed, producing small transient amounts of NO controlled by calcium levels. But iNOS is different. It's normally not expressed, but is dramatically upregulated under stress conditions, producing large sustained amounts of NO.
And the liver makes iNOS.
Yes. Hepatocytes, the main liver cells, were among the first parenchymal cells shown to express iNOS, and it can be expressed in all liver cell types when stimulated by inflammatory mediators or stress. Physiologically, NO from eNOS is primarily beneficial, helping maintain blood flow or perfusion within the liver microcirculation through vasodilation.
Okay, so baseline NO is good. What about during stress?
However, in inflammatory states like ischemia or perfusion, IR injury, where blood flow is temporarily interrupted and then restored, paradoxically causing damage NER's role gets complicated. While low-level eNOS-derived NO still tries to protect, the massive amounts of NO produced by iNOS can react with other harmful reactive oxygen and nitrogen species generated during a reperfusion injury. This reaction can form potent oxidants like peroxynitrite, significantly contributing to hepatocellular damage.
So it's a double-edged sword.
Absolutely. The ultimate effect depends on the source, eNOS versus INO, the type of injury, cold versus warm ischemia, and the overall liver environment. This dual nature means any attempt to therapeutically manipulate NO in liver disease requires an incredibly careful balancing act.
Another key molecular system in the liver that acts almost like the body's internal protector is the heme oxygenase system. What is it, and how does it contribute to safeguarding the liver from stress and damage?
The heme oxygenase, HO system, is indeed a vital endogenous cytoprotectant. HO is the rate-limiting enzyme that breaks down a component of hemoglobin and other proteins into biliverdin, carbon monoxide, CO, and free iron. Heme itself is toxic in excess because it can generate reactive oxygen species, so HO is a crucial defense mechanism just by getting rid of it.
And there are different types of HO.
Yes, HO1 is the inducible form, particularly important because it's activated by various cellular stresses like hypoxia, bacterial toxins like LPS, and ischemia or perfusion injury. It plays a critical role in maintaining the redox balance within cells during stress. The beauty is that the byproducts of this process, once thought to be just waste, are now recognized as key protectors themselves.
Like what?
Well, carbon monoxide, CO, at low physiological levels produced by HO1 actually has anti-inflammatory effects. It also helps maintain microcirculation by activating guanylyl cyclase. Then biliverdin gets rapidly converted to bilirubin, and both are powerful endogenous antioxidants, directly protecting against oxidative damage.
Bilirubin again, so it's not just waste.
Exactly. And even free iron, though potentially cytotoxic, is handled. HO1 induction also increases ferritin, a protein that safely sequesters free iron, leading to a net antioxidant effect. Overexpression of HO1 has shown hepatoprotective effects in models of various liver injuries, like IR injury or acetaminophen toxicity. This system and its products hold significant therapeutic promise for novel protective agents against hepatic inflammation.
So the liver is central to the systemic immune response, and toll-like receptors, or TLRs, sound like critical sensors. But it's a relatively recent and important realization that they're not just for infection, but also for detecting tissue damage, correct?
That's a very recent and important realization, yes. It has reshaped our understanding of the innate immune system. TLRs are indeed critical sensors that represent a common pathway for immunorecognition of both microbial invasion and tissue injury. They essentially act as danger sentinels, alerting the host to threats by activating the innate immune system, leading to inflammation and pathogen uptake. There are 11 TLRs identified in humans, each recognizing specific molecular patterns.
Patterns from microbes, originally.
Right. While initially identified for recognizing pathogen-associated molecular patterns, PAMPs, from bacteria or viruses like LPS, peptides, DNA, RNA studies have definitively shown that TLRs also recognize endogenous danger molecules. These are released from damaged or dying host cells, and we call them damage-associated molecular patterns, or DAMPs. Think of them as cellular distress signals.
Okay, so the immune system reacts to internal damage signals too.
Precisely. Perhaps more than any other TLR, TLR4 sits exactly at the interface of microbial and sterile inflammation. While its role in recognizing bacterial LPS is exceptionally well established, it's now clear that TLR4 also responds to these endogenous DAMPs released from injured tissues, things like heat shock proteins or components of the extracellular matrix. This crucial insight points to a shared molecular basis for innate immune activation by both infection and injury, fundamentally changing our understanding of immune responses in conditions like trauma, hemorrhagic shock, or ischemia.
Understanding the liver's function is one thing, but how do doctors actually see what's happening inside without cutting you open? What are the key imaging technologies that allow them to do this, and what unique insights does each provide?
That's where radiologic evaluation becomes indispensable, allowing us to visualize the liver's structure and even some of its function non-invasively. Each imaging modality offers unique advantages. Ultrasound is often the initial imaging test. It's accessible, low cost, no radiation. Patients tolerate it well.
How does it work?
It uses sound waves, the pulse echo principle, to create images, and Doppler flow can detect blood vessels and flow direction and velocity. It's excellent for diagnosing biliary pathology like gallstones and for finding focal liver lesions. It's also used in trauma fast exams.
But it has limitations.
It does. Sometimes you get incomplete imaging, like the dome of the liver hidden by ribs or interference from obesity or bowel gas. Lesion boundaries might not be clear. That's why ultrasound-detected masses often need further evaluation by CT or MRI, which generally have better sensitivity and specificity.
Are there advances in ultrasound?
Yes. Contrast-enhanced ultrasound using microbubbles improves delineation of lesions by showing dynamic enhancement patterns. Some agents even have a late liver-specific phase. An intraoperative ultrasound used during surgery is considered the gold standard for detecting lesions in real time. It finds 20–30% more lesions than preoperative scans and can influence surgical management significantly.
Wow.
It gives real-time info for staging, visualizing vessels, guiding resections or biopsies. And a really significant innovation is ultrasound elastography or transient elastography. It non-invasively assesses liver stiffness.
Measuring fibrosis.
Exactly. It measures how fast shear waves travel through the tissue, which correlates directly with fibrosis or cirrhosis. It's repeatable, covers more tissue than a biopsy, and has high sensitivity and specificity for diagnosing cirrhosis. It's really changing how we assess chronic liver disease.
CT scans are another incredibly common tool. How has this technology advanced to give us such detailed liver images, and what kind of crucial information do they provide for diagnosis and surgical planning?
Computed tomography, or CT, has been revolutionized by technologies like helical, spiral CT, and especially multi-detector row CT, MDCT. These allow for rapid, high-resolution cross-sectional imaging in a single breath hold. Think submillimeter section thickness.
A much finer detail, faster scans.
Exactly. This significantly reduces motion artifacts and allows for optimal timing of contrast delivery. Modern CT gives crucial morphological info on lesions number, size, distribution, vascularity. Contrast enhancement is routinely used for liver CT, leveraging the liver's dual blood supply. Usually a dual or triple phase injection of IV contrast is performed.
Why multiple phases?
To highlight different structures at different times, the arterial dominant phase, around 20–30 seconds post-injection, is key for hypervascular lesions, like many tumors, which get most of their blood from the hepatic artery. The later venous or portal dominant phase, around 60–70 seconds, provides optimal enhancement of the normal liver parenchyma because most of its blood comes from the portal vein. This phase allows detection of hypovascular lesions, which appear darker against the bright background.
And this helps surgical planning too.
Critically, these phases non-invasively map the complex hepatic, arterial, and venous anatomy, including those variants we discussed. This is absolutely vital for preoperative surgical planning. There's also a newer modality, CT cholangiography, which uses contrast excreted into bile ducts. It gives high-resolution views of the biliary tree and some functional information on bile flow. Useful for complex surgery or identifying obstructions, though less effective if ducts are very dilated or bilirubin is high.
MRI uses different physics to create images, relying on magnetic fields and radio waves. What are its unique advantages for liver evaluation compared to CT or ultrasound, especially in characterizing subtle lesions?
MRI's major advantages include its superior soft tissue contrast resolution and excellent depiction of fluid-containing structures like cysts or abscesses, all without using ionizing radiation.
So better detail for certain types of tissues.
Yes. And advances in imaging sequences, like single-breath T1-weighted imaging, have largely eliminated motion artifacts, making it highly effective for the abdomen. Like CT, MRI uses contrast agents, typically gadolinium-based, but what's truly revolutionary are the liver-specific MRI contrast agents. These agents are handled differently by liver cells. Some, like ferrum oxide, are taken up by Kupffer cells, the immune cells. Others, like gadoxetate, are actually taken up by hepatocytes and secreted into the bile.
So they show how the cells are working.
Precisely. They provide not just structural, but also crucial functional data, significantly improving lesion detection and characterization. For example, HCC often doesn't take up these agents like normal liver does, making it stand out. Similar to ultrasound, MR elastography is also used to assess liver stiffness for fibrocirrhosis, providing a comprehensive map of stiffness throughout the organ, potentially reducing the need for biopsies, though it's more expensive. And finally, magnetic resonance cholangiopancreatography, MRCP, provides a rapid, non-invasive depiction of both the biliary tree and the pancreatic duct without radiation or IV contrast. It's excellent for visualizing dilated bile ducts and assessing the level of obstruction, especially when combined with those liver-specific agents. MRI is a really powerful tool for intricate liver assessment.
PET scans are different still, looking at metabolic activity rather than just structure. How does that help in assessing liver disease, especially cancer, complementing the information from other imaging methods?
Positron emission tomography, or PET, provides crucial functional imaging at a molecular level. It detects gamma rays emitted from radioisotopes incorporated into metabolically active molecules like fluorodeoxyglucose, FDG, which is basically a radioactive sugar analog.
And cancers often use more sugar.
Many malignant tumors have increased glucose uptake and metabolism, so FDG-PET highlights these areas of abnormal metabolic activity as hotspots. Integrated PET-CT scanners have significantly improved diagnostic accuracy by overlaying the functional PT data onto the anatomical CT map. It's particularly sensitive for detecting liver metastases from various cancers, including colorectal, breast, and lung.
How is it used for colorectal cancer specifically?
For colorectal cancer, where hepatic metastases is very common, FDG-PET-CT is indispensable for accurate tumor staging and follow-up. It can detect occult intrahepatic metastases or extrahepatic disease spread outside the liver that might be missed by CT alone. This is critical because the presence of extrahepatic disease usually means aggressive surgery aimed at cure is not appropriate. Accurate staging is paramount.
Any caveats?
One professional point. Neoadjuvant chemotherapy, given before surgery, can sometimes lower FDG-PT sensitivity by reducing the tumor's metabolic activity, making it seem less hot.
What about primary liver tumors?
For primary liver tumors like HCC, FDG-PE utility is debated. Uptake correlates with tumor differentiation. High-grade, aggressive HCCs tend to show increased uptake, but low-grade, well-differentiated HCCs often don't. This leads to only about 50–65% sensitivity overall, which isn't sufficient by diagnosis alone. Dual tracer PET is being explored to improve this. For cholangiocarcinoma, FDG avidity varies, so it's not highly beneficial for initial diagnosis, but can be very useful for detecting regional and distal metastases, which, again, can significantly alter clinical decisions. PET truly provides a metabolic snapshot that complements the anatomical blueprint from other modalities.
With such a complex and critical organ, there are unfortunately many ways it can go wrong. Let's start with a severe, rapidly progressing emergency, acute liver failure. What exactly is it, and how does it manifest so quickly?
Acute liver failure, or ALF, is a critical and rapidly progressing syndrome. It's defined by the development of hepatic encephalopathy.
That's the decline in brain function.
Yes, altered mental status, confusion, progressing to coma, occurring within 26 weeks of severe liver injury in a patient with no prior history of liver disease or portal hypertension. This means the rate of hepatocyte death completely overwhelms the liver's remarkable regenerative capabilities.
How common is it?
ALF is rare, thankfully maybe 2,000 patients annually in the U.S., but it progresses very rapidly to hepatic coma and often death. The main causes of death are often intracranial hypertension due to brain swelling, sepsis, or multi-organ failure.
What causes ALF?
Its etiology varies geographically. In the East and developing world, viral infections like hepatitis B, A, or E are common. In the West, however, drugs and toxins are the main culprits, particularly acetaminophen overdose, accounting for about 65% of cases in the US, UK, and Australia.
Acetaminophen paracetamol, that's a huge percentage.
It is. It highlights a crucial public health issue. Other causes include autoimmune hepatitis, severe hypoperfusion, like from cardiogenic shock, pregnancy-related conditions like HLLP syndrome, and rare genetic conditions like Wilson's disease. About 20% of cases remain indeterminate. We just don't find a cause.
How do patients present?
Patients present rapidly with jaundice and then quickly progress to encephalopathy, often within days. They frequently have other organ dysfunctions like kidney failure or metabolic acidosis. Diagnosis requires a thorough history focusing on exposures, viral risks, all medications including over-the-counter toxins, herbal remedies, plus extensive lab work and sometimes a liver biopsy, often done transjugularly due to coagulopathy. Critically, early transfer to a specialized liver transplant center is vital.
And treatment?
Treatment specifics depend on the cause. For acetaminophen overdose within hours, activated charcoal can help. N-acetylcysteine, NAC, is the specific antidote administered early, which works by replenishing the liver's protective glutathione stores. NAC is even beneficial sometimes for ALF of unclear etiology. For all ALF patients, intensive care support is essential, managing fluids, electrolytes, preventing ulcers, monitoring hemodynamics, watching for infection, and especially managing intracranial pressure carefully. Sedation is generally avoided. Blood products are used cautiously.
What's the prognosis?
Identifying who might recover spontaneously is critical due to donor organ shortages. The King's College Hospital ALF criteria are widely used to predict prognosis based on factors like pH, clotting time, creatinine, and coma grade. But ultimately, orthotopic liver transplantation, OLT, is the only definitive therapy for those who can't regenerate sufficient liver mass. The advent of OLT has dramatically improved survival rates from less than 20% pre-transplant to over 70% currently, a testament to its life-saving impact. Emerging technologies like liver support devices, xenotransplantation, and cell transplantation are also being explored to bridge patients or reduce the need for donor organs.
While ALF is acute, cirrhosis is often a slow, relentless, progressive process. What's happening in the liver during cirrhosis, and what are its many devastating systemic complications?
Cirrhosis is indeed the final and most severe consequence of chronic liver injury from any cause. It's characterized pathologically by dense fibrous septa subdividing the liver parenchyma into abnormal hepatocellular nodules. Essentially, it's sustained wound healing gone terribly awry, leading to irreversible scarring and distortion of the liver architecture.
Is it always symptomatic?
No, about 40% of patients are initially asymptomatic, but progression to end-stage liver disease, ESLD, is typical, carrying a grim 5-year mortality of around 50%. Complications are extensive and devastating. Progressive jaundice, hyperbilirubinemia, severe malnutrition, profoundly decreased synthetic function, leading to low albumin and impaired blood clotting coagulopathy, and critically, portal hypertension.
Which causes ascites and varices.
Exactly. Fluid accumulation like ascites and life-threatening variceal bleeding, plus hepatic encephalopathy, the brain dysfunction. Cirrhosis is also the major risk factor for hepatocellular carcinoma, HCC, the most common primary liver cancer.
How does it look on imaging?
Radiographically, we often see characteristic changes like right hepatic lobe atrophy, compensatory hypertrophy of the caudate lobe and left lateral segment, a nodular liver surface, and signs of portal hypertension like splenomegaly, portal vein dilation, and visible collateral veins or varices.
What are the main causes of cirrhosis?
A wide range of diseases can lead to cirrhosis over time. Alcoholic liver disease remains a common culprit globally, but increasingly, non-alcoholic fatty liver disease, NAFLD, and non-alcoholic steatohepatitis, NASH, are the most common chronic liver diseases worldwide. NASH is the progressive form involving inflammation and injury, and about 1 in 10 NASH patients progress to cirrhosis and are at risk for HCC.
So many previously cryptogenic cases were likely NASH.
Yes, many cases previously labeled cryptogenic cirrhosis where no cause was found are now recognized as unrecognized NASH. Fatty liver disease also significantly increases risks after liver surgery. Chronic viral hepatitis, especially hepatitis C and B, also remains a major cause. Hep C is still the leading indication for liver transplantation in the U.S., though new treatments are changing that landscape. Hep B is a huge burden globally. Then there are autoimmune causes like primary biliary cirrhosis, PBC, and primary sclerosing cholangitis, PSC, and hereditary conditions like hemochromatosis, iron overload.
How do patients typically present clinically?
Clinically, patients may report nonspecific symptoms like fatigue, anorexia, weight loss, or more specific signs like jaundice, usually a late finding, abdominal pain or swelling from ascites, GI bleeding from varices, or confusion from encephalopathy. On physical exam, we look for stigmata of chronic liver disease, spider angiomata on the skin, pulmar erythema, red palms, finger clubbing, gynecomastia in males, and signs of portal hypertension like an enlarged spleen, splenomegaly, prominent abdominal veins, caput medusae, or asterixis, a flapping tremor associated with encephalopathy. Malnutrition is very common.
Any other systemic effects?
Yes. Cirrhotic patients also tend to have a hyperdynamic circulation, increased cardiac output, low blood pressure, and are highly prone to bacterial infections due to impaired immune function, like spontaneous bacterial peritonitis, SBP, in ascites fluid. And a critical professional insight. Intrinsic drug metabolism is often significantly reduced, meaning medication doses often need careful adjustment.
What about lab findings?
Lab findings typically show mild anemia, low white blood cell and platelet counts due to hypersplenism, a prolonged PTINR, unresponsive to vitamin K in severe disease, and low albumin. Bilirubin, transaminases, ASTALT, and alkaline phosphatase may be elevated, but crucially, normal LFTs do not rule out compensated cirrhosis because of the liver's vast reserve capacity.
How do doctors confirm cirrhosis and critically assess the risk of surgery for these patients, given how delicate their condition can be?
While clinical features, labs, and imaging often strongly suggest cirrhosis, a liver biopsy, percutaneous, transjugular, or laparoscopic, is sometimes still considered the gold standard to confirm the diagnosis, identify the cause, assess the degree of inflammation and fibrosis, and stage the progression.
But biopsies have risks.
Yes, especially bleeding in patients with coagulopathy. Non-invasive markers like ultrasound elastography, FibroScan, or Messier elastography are increasingly used as promising alternatives to biopsy for staging fibrosis.
And assessing surgical risk. That seems paramount.
Absolutely critical. Cirrhosis and portal hypertension significantly increase the risks for non-transplant surgeries, especially emergency operations, cardiac surgery, or major abdominal procedures like liver resection itself. Preoperative factors like anemia, ascites, encephalopathy, malnutrition, infection, jaundice, significant portal hypertension, and prolonged PTINR are all associated with worse outcomes. Severe decompensated chronic hepatitis or acute fulminant hepatitis are generally contraindications for elective non-transplant surgery. Two main scoring systems are used routinely to quantify this risk.
The Child-Pugh score.
Yes, the Child-Turcotte-Pugh CTP score. Originally developed for portocaval shunt risk, it's now widely used for general surgical risk stratification in cirrhotic patients. It classifies patients into Class A, lowest risk, maybe 10% mortality for major surgery, B, moderate risk, 30% mortality, and C, very high risk, 75-80% mortality, based on 5 variables: bilirubin, albumin, INR, and subjective assessments of encephalopathy and ascites severity.
Subjective assessment.
Yeah.
That's a limitation.
It is. The subjectivity of ascites and encephalopathy grading, its narrow range, and equal weighting of variables are limitations, which led to the development of the second system,
MELD.
the Model for End-Stage Liver Disease, MELD, scoring system. This is a linear regression model based on 3 objective lab values: INR, serum bilirubin, and serum creatinine. It was originally developed to predict mortality after TIPS procedures, but it proved so effective that it's been the sole method for prioritizing adult liver transplant allocation in the U.S. since 2002. MELD scores correlate well with CTP classes, and studies suggest a MELD score below 10 allows for relatively safe elective surgery, 10-15 requires significant caution, and scores exceeding 15 generally mean elective non-transplant surgery should be avoided due to prohibitive risk. Mortality risk increases by about 1–2% for each MELD point increase. It's a much more objective and granular system.
Portal hypertension is a major life-threatening complication of cirrhosis. What exactly is it, and how does that elevated pressure lead to such severe issues like vertebral bleeding?
Portal hypertension is simply elevated pressure within the portal venous system. Remember, this system normally supplies 75% of the liver's blood at a low pressure, typically 5–10 mmHg. When resistance to blood flow through the liver increases, most commonly due to the scarring and structural distortion of cirrhosis in the U.S., the pressure in this valveless system rises significantly. Anything above 12 mmHg is considered clinically significant portal hypertension.
And because it's valveless.
Because it's valveless and drains much of the GI tract, spleen, and pancreas, this increased pressure forces blood to seek alternative low-pressure routes back to the systemic circulation. It does this via collateral communications connections between the portal system and the systemic venous system that are normally tiny or closed. These collaterals become engorged and dilated under high pressure, forming varices.
Where do these usually form?
Most commonly at the gastroesophageal junction, esophageal and gastric varices, but also in the rectum, anorectal varices, distinct from hemorrhoids, and around the umbilicus via a reopened umbilical vein, leading to caput meduso. Esophageal and gastric varices are the most dangerous because they are prone to rupture and massive, life-threatening bleeding.
How is portal hypertension diagnosed or measured?
Abdominal ultrasonography with Doppler is usually the initial investigation. It can assess portal vein patency, look for thrombosis, check flow direction, and evaluate the size of the spleen and presence of ascites or collaterals. CT and MRA also show the anatomy well. Invasive methods like direct portography are rarely needed. Hepatic venography is the most accurate method to actually measure portal hypertension. A catheter is placed into a hepatic vein, and pressures are measured with and without a balloon occluding the vein, wedged versus free pressure. The difference, the hepatic venous pressure gradient, HVPG, directly reflects the pressure gradient across the liver sinusoids and is the best measure of portal hypertension severity. An HVPG above 12 mmHg correlates with variceal bleeding risk.
Besides cirrhosis, are there other causes?
While cirrhosis is the most common cause of portal hypertension, intrahepatic sinusoidal, other causes exist. Presinusoidal causes include portal or splenic vein thrombosis or schistosomiasis. Post-sinusoidal causes include Budd-Chiari syndrome, hepatic vein obstruction, or right-sided heart failure causing congestion. Clinically, besides varices, portal hypertension leads to splenomegaly, enlarged spleen, with hypersplenism, low blood counts due to sequestration in the spleen, and contributes significantly to ascites development along with the low albumin from liver dysfunction.
Variceal bleeding is truly a life-threatening emergency. How is it prevented in the first place? And then if it happens, how is it managed in a high-stakes, acute situation?
It absolutely is. Variceal bleeding is the leading cause of morbidity and mortality directly related to portal hypertension, with a daunting 20–30% mortality risk per bleeding episode. Prevention is therefore paramount. For primary prevention, preventing a first bleed, non-selective beta blockers like propranolol or nadolol are standard therapy. They reduce cardiac output and cause splanchnic vasoconstriction, lowering portal pressure. They reduce the risk of a first variceal bleed by about 45% and bleeding-related mortality by 50%.
Wow, that's effective.
Very effective. For patients with medium to large varices found on screening endoscopy, prophylactic endoscopic variceal band ligation, EVL, placing small elastic bands around the varices to obliterate them, is also recommended and reduces the incidence of a first bleed.
Okay, but what if bleeding occurs acutely?
When acute hemorrhage occurs, it's an ICU emergency requiring a multi-pronged approach. First, careful resuscitation. The target hemoglobin is often around 8 GDL. Overzealous fluid or blood replacement must be avoided as it can increase portal pressure and worsen rebleeding. Coagulopathy should be corrected if severe, often with fresh frozen plasma and platelets. Prophylactic antibiotics like ceftriaxone are crucial. Cirrhotic patients with bleeding are highly prone to bacterial infections, which significantly worsen outcomes and increase mortality. Antibiotics improve survival.
Then stop the bleeding directly.
Yes. Vasoactive medications are given immediately to decrease splanchnic blood flow and portal pressure. Octreotide, a somatostatin analog, is preferred over vasopressin due to fewer systemic side effects. Then urgent endoscopy within 12 hours, ideally, with variceal band ligation is the mainstay of treatment. It's highly effective at stopping active bleeding and preventing early rebleeding, especially when combined with vasoactive drugs.
What if endoscopy fails or isn't immediately possible?
If bleeding is refractory or massive, temporary luminal tamponade with a specialized balloon tube, like a Sengstake and Blakemore tube, can be used. It controls bleeding in up to 90% of cases by direct pressure. However, it carries high complication risks like aspiration, airway obstruction, or esophageal perforation, so it's only a temporary bridge, less than 36 hours, to more definitive measures.
What are those definitive measures for refractory bleeding?
The primary rescue therapy is transjugular intrahepatic portosystemic shunt, TPS. This is performed by interventional radiologists. A metallic stent is implanted percutaneously through the jugular vein, creating a bypass channel within the liver between an intrahepatic portal vein branch and a hepatic vein radical. This effectively shunts blood away from the portal system, reducing portal pressure. Goal HVPG at 12 mmHg.
How effective is TPS?
It has a high technical success rate, around 95%, and controls refractory variceal bleeding in over 90% of cases. Importantly, it doesn't preclude future liver transplantation. However, TPS has potential complications, including bleeding, infection, renal failure, worsening liver function, and notably, hepatic encephalopathy in 25–30% of patients due to shunting of gut-derived toxins past the liver. The shunt can also thrombose or stenose over time, requiring follow-up interventions to maintain patency.
Any other options besides TIPS?
For bleeding gastric varices, particularly those associated with spontaneous shunts, like gastrorenal shunts, balloon-occluded retrograde transvenous obliteration, BRTO, is an alternative. A balloon catheter is used to block the shunt outflow, and a sclerosing agent is injected to obliterate the varices. BRTO effectively controls hemorrhage and, importantly, preserves portal flow to the liver, reducing the risk of encephalopathy compared to TIPS. However, it can worsen portal hypertension elsewhere, potentially exacerbating esophageal varices or ascites. Surgical shunting is now much less common due to the success of TIPS and OLT. It's generally reserved for non-transplant candidates or those with failed TIPS or limited access. Various shunt types exist, aiming to reduce portal pressure while ideally maintaining some liver perfusion and avoiding encephalopathy. The distal splenorenal Warren shunt is often preferred as it selectively decompresses gastroesophageal varices and doesn't interfere with OLT. Ultimately, for patients with end-stage liver disease presenting with variceal bleeding, hepatic transplantation is the definitive therapy. It addresses the underlying cirrhosis and portal hypertension, reversing most complications. Prior endoscopic ligation, TIPS, or certain surgical shunts don't preclude transplants, though some shunts make it technically harder.
A lesser-known but critical liver condition is Budd-Chiari syndrome. What is it, why is it so serious, and how does it differ from other liver diseases causing portal hypertension?
Budd-Chiari syndrome, or BCS, is an uncommon but very serious congestive hepatopathy. Unlike cirrhosis, where the blockage is within the liver sinusoids, BCS is caused by obstruction of the hepatic venous outflow, the veins draining blood out of the liver. This obstruction can be primary, due to a thrombus or clot within the hepatic veins or the IVC, or secondary, due to compression or invasion by a neighboring lesion, like a tumor. It affects maybe 1 in 100,000 people globally.
What causes the primary thrombosis?
About 75–90% of primary BCS cases have underlying thrombotic risk factors. Primary myeloproliferative disorders like essential thrombocythemia or polycythemia rubra vera, which cause overproduction of blood cells, account for a large portion, maybe 35–50%. Inherited thrombophilias like factor V Leiden mutation, protein CRS deficiency, autoimmune conditions like antiphospholipid syndrome, and even oral contraceptive use are also implicated. Often, multiple factors are present.
How does it present clinically?
Clinically significant BCS usually results from obstruction of 2 or more major hepatic veins. This leads to blood backing up in the liver, causing massive liver congestion, enlargement hepatomegaly, right upper quadrant pain, and often rapid development of ascites. Portal vein perfusion may decrease, and liver biopsy often shows characteristic central lobular necrosis due to congestion. While acute liver failure is rare, most patients develop chronic portal hypertension complications if untreated. A characteristic finding on imaging in about 50% of cases is caudate lobe hypertrophy. Because the caudate lobe often has direct venous drainage into the IVC, it may be spared from the congestion and enlarged, sometimes even compressing the IVC further.
How is it diagnosed and treated?
Diagnosis often starts with abdominal ultrasound with Doppler, which can show absent flow in hepatic veins, thrombus, characteristic spiderweb collaterals within the liver, or reversed flow in the portal vein. CT or MRI can also show thrombosis, but aren't as good for assessing flow dynamics. Hepatic phenography is the definitive study, confirming the diagnosis, assessing the extent of thrombus, and measuring pressures. Initial treatment focuses on diagnosing and managing the underlying prothrombotic condition and preventing further clot extension with lifelong systemic anticoagulation. Portal hypertension and ascites are managed medically as in cirrhosis. For patients who don't respond or have severe symptoms, interventions are needed to restore outflow. Percutaneous angioplasty with stenting of stenosed veins combined with thrombolytic therapy, clot-busting drugs, for acute thrombus can be effective. TIPPs can also be used to create an outflow pathway if the hepatic veins are occluded but the IVC is open. Surgical shunting is rarely used now but can sometimes turn the portal vein into an outflow tract. Ultimately, hepatic transplantation is the definitive treatment for progressive BCS leading to end-stage liver disease manifestations.
The liver's role in the immune system is evident through its ability to handle constant exposure to gut bacteria. But some infections can establish a foothold. What are the common non-viral ones that professionals need to be aware of, and how do they present uniquely?
Despite the liver's robust reticuloendothelial system, especially those Kupffer cells, non-viral infections can occur and cause significant problems. The most common type of liver abscess in developed countries are pyogenic liver abscesses, which are bacterial. They can be single or multiple, often in the right lobe.
What causes them?
Historically, many came from intestinal infections like appendicitis spreading via the portal vein, but that's less common now. Current causes often include impaired biliary drainage, like from stones or strictures, systemic infections like endocarditis spreading via the hepatic artery, indwelling catheters, or sometimes direct extension from adjacent infections. Immunosuppressed patients are at higher risk. About half are polymicrobial, often involving gram-negatives like E. coli or Klebsiella, and anaerobes like bacteroids.
How do they present?
Typically with right upper quadrant pain, fever, chills, and often elevated white blood cell count and inflammatory markers like ESR and AP. Jaundice occurs in about a third. Blood cultures are positive in about half. Ultrasound or CT usually shows a low-density lesion, sometimes with peripheral enhancement or internal echoes fluid levels. Treatment involves correcting the underlying cause, if possible. Prolonged IV antibiotics, often 6 to 8 weeks, and usually drainage, either percutaneous needle aspiration catheter drainage guided by imaging, or sometimes surgical drainage and percutaneous fails or the abscess is very viscous. It's crucial to differentiate these from a necrotic hepatic malignancy, which can look similar.
Okay, what about non-bacterial abscesses?
Amoebic abscesses are caused by the parasite Entamoeba histolytica. This is much more common worldwide, particularly in subtropical climates with poor sanitation. Cysts are ingested, transform into invasive trophozoites in the colon, invade the mucosa, and enter the portal system to reach the liver. They typically form a single large abscess, often in the superior anterior right lobe, containing necrotic anchovy paste pus. Patients often have a history of travel to an endemic area, right upper quadrant pain, fever, and hepatomegaly. Diarrhea is unusual. Diagnosis is supported by serologic tests. Positive fluorescent antibody test. Ultrasound CT show the abscess, often with wall enhancement. Treatment is usually very effective with metronidazole. Aspiration is rarely needed.
Any other parasitic infections?
Yes, hydatid disease is an infection by the larval cyst stage of the tapeworm Echinococcus granulosus. It's common in sheep raising areas. Humans are accidental hosts, ingesting ova from dog feces. The larvae travel, most commonly lodging in the liver, about 70% of cysts, forming large, complex cysts. They can be silent or cause dull pain. Complications include secondary infection or rupture, which can cause a severe allergic or anaphylactic reaction and spread daughter cysts. Diagnosis uses imaging, showing characteristics of cysts, sometimes with calcification or daughter cyst, and serology, ELISA for echinococcal antigens. Treatment is primarily surgical removal of the intact cyst, using scolicidal agents carefully to avoid spillage. Medical treatment with albendazole is used for some small cysts or adjunctively.
Are there worm infections too?
Yes, ascariasis, caused by the roundworm Ascaris lumbricoides, is common in parts of Asia and Africa. Adult worms can migrate from the GI tract into the bile ducts, causing biliary colic, obstruction, cholangitis, abscesses, and even pancreatitis. Diagnosis involves seeing the worms on imaging, ultrasound, ERCP. Treatment is with antihelminthics and often endoscopic extraction. And schistosomiasis, caused by fluke worms, affects over 200 million globally. Ova lodge in the portal venules of the liver, causing a granulomatous reaction and progressive periportal fibrosis. pipestem fibrosis. This leads to presinusoidal portal hypertension with splenomegaly and varices, while hepatocellular function is often preserved until late. Diagnosis is by finding ova in stool or biopsy or serology. Treatment is with praziquantel and managing portal hypertension complications.
And just to reiterate, viral hepatitis B and C are major causes of chronic liver disease, leading to cirrhosis and cancer.
Absolutely. While Hep A is acute, hepatitis B and C are the major drivers of chronic liver disease, cirrhosis, and HCC worldwide. Effective antiviral therapies now exist for both, aiming for viral suppression or eradication to prevent or reverse these long-term complications. Management, especially for chronic Hep C, is complex and involves considering viral genotype, fibrosis stage, and treatment regimens.
Masses and tumors, diagnosis and treatment.
Finding a liver mass, incidentally, often during imaging for something else, can be incredibly alarming for patients. How do clinicians systematically evaluate these findings to determine if they're benign or malignant without jumping to conclusions? And what's the diagnostic algorithm?
An incidental liver mass indeed requires a thorough and orderly diagnostic algorithm to minimize unnecessary testing and anxiety, while accurately assessing the risk of malignancy. The process begins, always, with a comprehensive history and physical examination.
Looking for clues.
It's exactly any abdominal pain, weight loss, personal or family history of liver disease or cancer, risk factors like alcohol use or viral hepatitis, medication history, especially hormones, tattoos, transfusions, symptoms of jaundice, and a physical exam looking for jaundice, liver enlargement, a palpable mass, or stigmata of portal hypertension. This is followed by a broad laboratory workup. CBC, electrolytes, kidney function, glucose, albumin, the full panel of LFTs, coagulation studies, maybe serum ammonia, hepatitis screen, and specific tumor markers like alpha-fetoprotein, AFP for HEC, carcinoembryonic antigen, CEA for colorectal mets, or CA19-9 for biliary or pancreatic cancer.
Then imaging, presumably.
Yes, imaging studies are crucial. While an ultrasound or CT might have initially discovered the mass, further detailed radiologic evaluation is often necessary for characterization. This commonly involves dedicated liver protocol, dual or triple-phase CT scans, or MRI with contrast. These leverage the distinct appearances and contrast enhancement patterns of different lesions to help differentiate benign from malignant. Liver-specific MRI contrast agents, as we discussed, can provide additional functional data, further improving characterization. CT cholangiography, or MRCP, might be used if biliary involvement is suspected. For suspected malignancy, especially metastases, FDG-PDCT has become an indispensable tool for accurate disease staging and follow-up, identifying both the primary lesion and any spread.
What if malignancy is suspected but the source isn't clear?
Then an occult primary evaluation may be needed. This might involve upper endoscopy, EGD, colonoscopy, mammogram, or gynecologic evaluation, depending on the clinical picture and tumor markers. Finally, a liver biopsy is indicated when biochemical analysis and diagnostic imaging remain inconclusive, and a definitive tissue diagnosis is needed to guide management. This is often performed percutaneously with ultrasound or CT guidance. However, absolute contraindications include significant coagulopathy or strong suspicion of a hemangioma or echinococcal cyst due to risks of bleeding or anaphylaxis. In cases of obesity or ascites, a laparoscopic biopsy might be preferred. Increasingly, though, sophisticated imaging is reducing the need for biopsy for many common lesions.
Cysts are a very common incidental finding in the liver. Are they always benign, and how are they managed differently depending on their specific type?
That's an excellent question, as cysts can encompass a variety of lesions, and their nature and management do vary significantly. It's not always simple. Congenital cysts, often called simple cysts, are the most frequent liver lesion overall. They result from excluded bile duct rests, appearing as thin-walled, fluid-filled structures. Most are incidental and asymptomatic.
So usually nothing to worry about.
Generally, yes. Asymptomatic simple cysts are managed conservatively with observation. If they become large enough to cause symptoms like pain or fullness, treatment involves ultrasound or CT-guided percutaneous aspiration, followed by sclerotherapy, injecting a substance to scar down the lining, which is effective in about 90% of cases. If that fails, laparoscopic or open surgical cyst fenestration, unroofing the cyst, is an option. Critically, any excised cyst wall must be sent for pathology to rule out a cystadenocarcinoma.
So some cysts can be malignant.
Yes. Biliary cystadenomas are uncommon, slow-growing lesions, usually large, often in the right lobe. While benign initially, they have a significant potential to undergo malignant transformation into cystadenocarcinoma. They often present with abdominal pain or a mass. Imaging shows thicker walls, internal septations, and sometimes enhancing nodules. Because of the malignant risk, surgical resection is the preferred treatment.
What about multiple cysts?
That often indicates polycystic liver disease, PCLD. This is an autosomal dominant genetic disorder, frequently associated with polycystic kidney disease, PKD, linked to PKD1, PKD2 gene mutations. Cysts become more prevalent with age, especially in females. Many patients remain asymptomatic, but if cysts become numerous or very large, they can cause significant symptoms like abdominal pain, distension, shortness of breath, or early satiety due to compression. Liver synthetic function is often remarkably preserved despite the extensive cystic replacement, but complications like cyst hemorrhage, infection, or rupture can occur. Renal failure may develop if associated PKD is severe.
How is PCLD treated?
Treatment for symptomatic PCLD aims to ameliorate symptoms by decreasing liver volume. Medical options like somatostatin analogs are experimental. Cyst aspiration and sclerotherapy can target dominant large cysts. Surgical cyst fenestration, laparoscopic or open, can treat multiple cysts, but carries risks and recurrence is common. For very severe disease, hepatic resection, if a spared segment exists, or orthotopic liver transplantation, OLT, is considered. OLT is the definitive therapy for severely disabling symptoms or complications, and combined liver-kidney transplant may be needed for severe renal insufficiency.
And one more cystic condition.
Caroli's disease. This is a rare congenital condition involving segmental cystic dilatation of the intrahepatic biliary radicals due to ductal plate malformations. It's associated with biliary stone formation within the cyst, recurrent cholangitis, bile duct infection, abscess formation, and sometimes cystic renal disease. Patients often present by age 30 with fever, chills, and abdominal pain. Critically, there's about a 7% risk of developing cholangiocarcinoma within the cysts. Diagnosis relies on imaging, MRCP, ERCP, showing communication of the cysts with the biliary tree. Treatment involves biliary drainage for infection and hepatic resection if the disease is confined to a single lobe, or for complications like recurrent cholangitis or suspected malignancy. So while they all involve cysts, the implications are vastly different.
Beyond cysts, what are the other common benign solid lesions in the liver, and why is it so important to differentiate them from something more serious, especially since they can sometimes mimic malignant tumors on imaging?
It's paramount to differentiate benign solid lesions from malignancies because they are much more common than malignant tumors, affecting up to 20% of the population incidentally. Misdiagnosis can lead to unnecessary major surgery for a benign lesion, or conversely, delay necessary cancer treatment if a malignancy is mistaken for benign. The most common solid benign liver mass is a hemangioma. These are essentially congenital tangles of blood vessels, endothelial-lined vascular spaces. They are predominantly found in women, ranging from tiny to giant, over 10 centimeters.
Are they dangerous?
Most are incidental and asymptomatic. Large ones can cause symptoms from compression or rarely thrombosis, but spontaneous rupture is exceedingly rare. Imaging, particularly contrast-enhanced CT or MRI, is usually diagnostic, showing characteristic patterns of peripheral nodular enhancement that fills in centrally over time. Liver biopsy is generally avoided due to the risk of bleeding. Surgical resection is only considered if they are clearly symptomatic.
Okay, what's next?
Adenoma, or hepatocellular adenoma. These are benign, solid neoplasms composed of hepatocytes, most common in premenopausal women over 30, and strongly linked to oral contraceptive use or other hormonal stimuli. They typically lack normal portal tracts and bile ducts. Imaging shows a well-defined lesion, often hypervascular on the arterial phase of CT or MRI. Liver-specific MRI contrast agents are very helpful in distinguishing them from FNH.
What are the risks with adenomas?
This is critical. Adenomas carry a significant risk of spontaneous rupture with intraperitoneal bleeding, which can be life-threatening, presenting this way in 10–25% of cases. They also have a risk of malignant transformation into well-differentiated hepatocellular carcinoma, HCC. Because of these risks, surgical resection is generally recommended for large adenomas, typically those over 4 to 5 centimeters or those that are growing or symptomatic. Discontinuing oral contraceptives is also advised.
And the third common one?
Focal nodular hyperplasia, FNH. This is believed to be a hyperplastic regenerative response of hepatocytes to an anomalous artery within the lesion. Like adenomas, it's more common in women of childbearing age, but the link to oral contraceptives is less clear. Imaging is often diagnostic. A good quality biphasic CT or MRI typically shows a well-circumscribed lesion with intense homogeneous enhancement on the arterial phase, often with a characteristic central scar that enhances on delayed images. Liver-specific MRI contrast usually shows uptake similar to normal liver, unlike adenomas.
What are the risks with FNH?
Unlike adenomas, FNH usually does not rupture spontaneously and, crucially, has no significant risk of malignant transformation. Therefore, management of FNH is typically reassurance and observation, regardless of size. Surgical resection is only considered if the patient is symptomatic, which is rare, or if imaging is atypical and an adenoma or HCC cannot be definitively excluded. Discontinuing OCPs is often recommended if diagnosed. Understanding these distinct characteristics and risks, especially the bleeding and cancer risk with adenomas versus the benign nature of FNH, is paramount for accurate diagnosis and appropriate patient management.
Now, let's talk about the more serious masses, malignant tumors. What are the main types, and how do they differ in origin, prevalence, and behavior, which dictates their complex treatment strategies?
Malignant liver tumors are broadly classified as either primary, originating from the liver cells, hepatocytes, or bile duct cells, the cholangiocytes, or metastatic, meaning they have spread to the liver from a cancer originating elsewhere in the body.
Which are more common?
In the U.S. and most Western countries, metastatic tumors are far more common than primary liver cancers. The most frequent tumor encountered in the liver overall is metastatic colorectal cancer, CLM, which affects over 50–60% of patients with colorectal cancer at some point. Hepatocellular carcinoma, HCC, is the most common primary liver cancer globally, and in the U.S., around 30,000 new cases annually stateside. Other primary cancers like cholangiocarcinoma or other metastases like neuroendocrine tumors also contribute. Let's start with HCC. Hepatocellular carcinoma, HCC, is the fifth and most common malignancy worldwide and the third leading cause of cancer death globally. Its incidence is rising in many Western countries. Major risk factors are strongly linked to chronic liver disease and cirrhosis, primarily chronic viral hepatitis B or C, alcoholic cirrhosis, increasingly NASH, non-alcoholic steatohepatitis, and hereditary conditions like hemochromatosis. HCC arises within a cirrhotic liver in 70–90% of cases.
How does it behave?
HCC is typically hypervascular, getting most of its blood supply from the hepatic artery. This leads to characteristic imaging findings. Bright enhancement on the arterial phase of CT or MRI, followed by relatively rapid washout of contrast on delayed phases compared to the surrounding liver. MRI is particularly effective for diagnosis. HCC also has a notorious tendency to invade blood vessels, especially the portal vein. And enhancing thrombus within the portal vein is highly suggestive of HCC.
How is HCC managed?
Management is complex and ideally handled by a multidisciplinary liver transplant team. Surgical resection offers the best chance for cure, but is only suitable for patients with well-preserved liver function, non-cirrhotic or Child's class, a cirrhosis without significant portal hypertension, and tumor confined to the liver. If resection is not possible due to poor liver function or advanced tumor stage, orthotopic liver transplantation, OLT, is the treatment of choice, provided the HCC meets specific transplant criteria, like the Milan criteria, single tumor of 5 centimeters, or up to 3 tumors each, A3 centimeters, with no vascular invasion or extrahepatic spread. These criteria aim to select patients with the lowest risk of recurrence after transplant. Guidelines like those from the Barcelona Clinic Liver Cancer Group help stratify patients and guide treatment decisions, which also include locoregional therapies like ablation or chemoembolisation for intermediate stages. Living donor liver transplantation is an important alternative in regions with long waiting lists or organ shortages.
Okay, what about the second most common primary, cholangiocarcinoma?
Cholangiocarcinoma, bile duct cancer, is an adenocarcinoma arising from the bile duct epithelium. It's much rarer than HCC. It's classified based on location. Peripheral or intrahepatic cholangiocarcinoma rises from smaller bile ducts within the liver substance, often presenting as a tumor mass. Central or extrahepatic cholangiocarcinoma arises from the larger bile ducts outside the liver parenchyma. The most common type of central is a hilar cholangiocarcinoma, also known as a Klatskin's tumor, originating right at the confluence where the right and left hepatic ducts join. These usually present with obstructive jaundice, rather than a distinct mass initially.
How does it behave differently from HCC?
Cholangiocarcinoma, especially the hilar type, is notoriously difficult to diagnose early. It tends to grow infiltratively along the bile ducts and frequently metastasizes early to regional lymph nodes. Biopsy shows adenocarcinoma, but differentiating it from metastatic adenocarcinoma, for example from pancreas or colon, requires excluding an extrahepatic primary source. Surgical resection offers the only potential for cure, but achieving negative margins is challenging, especially for hilar tumors. The operative approach depends heavily on the location and extent. For hilar cholangiocarcinoma, resection often requires concomitant major hepatic resection, removing part of the liver along with the bile duct bifurcation, and lymph node dissection to achieve cure. OLT for hilar cholangiocarcinoma had disappointing initial results due to high recurrence. However, protocols like the one developed at the Mayo Clinic, involving careful patient selection, neoadjuvant chemoradiation before transplant, and staging laparoscopy, have shown dramatically improved 5-year survival rates, around 70%, comparable to resection for eligible patients. Eligibility criteria are strict, though. For peripheral cholangiocarcinoma, resection offers reasonable survival, but OLT is generally not routine due to high recurrence rates post-transplant.
What about gallbladder cancer?
Gallbladder cancer is rare, but highly aggressive, with a very poor prognosis. Over 90% of cases are associated with gallstones. Chronic inflammation likely plays a role. It's often diagnosed incidentally after a routine cholecystectomy for presumed gallstones. Treatment depends on the stage found incidentally. For anything beyond a very early stage, T1A, reoperation with a central liver resection, removing the gallbladder bed, hilar lymphadenectomy, and checking the cystic duct stump margin is typically recommended and improves survival compared to cholecystectomy alone. Results for more advanced disease are generally dismal.
And back to the most common liver tumor overall, metastatic colorectal cancer.
Yes, metastatic colorectal cancer, CLM. The liver is the most common site of distant spread for colorectal cancer. Hepatic resection for CLM has become standard of care and has shown clear survival benefits, offering a chance for cure in selected patients. Importantly, the criteria for resectability have evolved significantly. Traditional thinking, like only resecting fewer than 4 metastases, has been challenged. More recent studies show that long-term survival can be achieved even in patients with numerous nodules, provided all disease can be safely removed.
So resectability isn't just about the number of tumors.
Exactly. Resectability is now redefined not just by what is removed, but by ensuring an adequate volume and function of the future liver remnant, FLR, and considering the health of the background liver. Advances in chemotherapy, especially effective neoadjuvant chemo that can shrink tumors, surgical techniques like PVE to grow the FLR, 2-stage hepatectomy, simultaneous ablation of unresectable lesions, and even resection of limited extrahepatic tumor have dramatically increased the number of patients eligible for potentially curative surgical approaches.
What about metastases from other cancers, like neuroendocrine tumors?
Neuroendocrine tumors, NETs, often metastasize to the liver. These metastases typically have a more protracted, slower-growing natural history than other cancers, but they can cause debilitating symptoms due to hormone overproduction, carcinoid syndrome, hypoglycemia, etc. Because of this, aggressive surgical debulking or resection of NET liver metastases is often advocated, even if cures isn't possible, to control symptoms and potentially extend survival. Studies show respectable long-term survival after resection. Multimodal therapies, including ablation, chemoembolisation, or radioembolization, yttrium-90 microspheres, are also used. OLT is considered only for highly selected patients meeting specific criteria.
And metastases from cancers like breast or kidney.
Historically, resection of liver metastases from non-colorectal, non-neuroendocrine primaries was viewed less enthusiastically, often considered a sign of widespread, incurable systemic disease. However, more recent studies are showing acceptable 5-year survival rates in the 20–40% range after resection of hepatic metastases from selected primaries like breast, renal, melanoma, or certain GI cancers, particularly if the disease-free interval was long and extrahepatic disease is absent. Patient selection remains crucial, but the dogma against resecting these is softening.
The art of liver surgery, techniques and innovations.
Given the liver's complexity, its incredible vascularity, and its central role in so many cancers and conditions, surgical techniques must be incredibly advanced. How has liver surgery evolved to meet these challenges, especially in minimizing that dreaded blood loss and improving precision?
Liver surgery has indeed undergone a remarkable evolution, particularly over the last 50 years. The overarching goal has been to perform safer, more precise surgery, often aiming for what surgeons call bloodless surgery, which significantly minimizes complications and improves patient outcomes. One key aspect facilitating this was standardizing the language. The Brisbane 2000 Consensus introduced universal nomenclature for liver anatomy, lobes, sections, sectors, segments, and surgical procedures.
So everyone speaks the same language.
Exactly. For instance, standardizing right hepatic lobectomy to right hepatectomy enables clearer communication and comparison of outcomes among surgeons worldwide. In terms of parenchymal division techniques, actually cutting through the liver tissue, innovations in technology have dramatically expanded the surgeon's toolkit. We've moved beyond simple blunt fracture or basic cautery to sophisticated tools like ultrasonic dissectors, like the CUSA, which use high-frequency vibrations to emulsify liver tissue while preserving blood vessels and bile ducts within it.
Letting surgeons see what they need to tie off.
Precisely. Other tools include water jet dissectors, advanced bipolar sealing devices like ligature or end-seal that fuse tissue and vessels, radiofrequency ablation probes used for transection like Habib 4X, and various topical hemostatic agents, fibrin glues, oxidized cellulose. A significant trend is the increasing use of vascular stapling devices for dividing the major hepatic veins and portal vein branches during transection.
How do staplers help?
They allow for rapid, secure division of large vessels, which significantly speeds up the transection phase, minimizes blood loss from the raw surface, and reduces the total ischemia time for the remnant liver if inflow occlusion is used. While these disposables add cost, it's often offset by benefits like reduced need for blood transfusions, shorter operating room time, and potentially fewer ICU admissions. Bile leaks were an initial concern, but are rare with proper technique. These technological advancements, combined with a deeper anatomical understanding, have truly transformed liver surgery.
This sounds like an incredibly choreographed, high-stakes procedure. What are the general steps and key principles surgeons follow for these major liver resections to achieve that bloodless approach you mentioned?
It absolutely is a masterclass in anatomical knowledge, technical skill, and careful planning. Mastery of orderly steps, combined with that deep knowledge of liver anatomy and its common variants, is the foundation of safe hepatic surgery. While techniques vary, common steps for open major hepatic resections include: first, access and exploration. Making the appropriate incision, like a right subcostal chevron or J shape, opening the abdomen, placing retractors for exposure, and then performing a thorough bimanual palpation of the liver and, crucially, an intraoperative ultrasound.
Ultrasound during surgery.
Yes, it's essential. It confirms the preoperative findings, precisely locates the tumor relative to major vessels, identifies any additional lesions missed preoperatively, and helps map out the planned resection plane. Second, mobilization. This involves carefully dividing the ligaments that attach the liver to the abdominal wall and diaphragm, like the falciform, coronary, and triangular ligaments. This essentially frees up the lobe to be resected, allowing for safe rotation and access to the deep structures, especially the hepatic veins and IVC behind the liver. Third, hilar dissection. This means carefully dissecting within the porta hepatis that gateway containing the hepatic artery, portal vein, and bile duct. The goal is to identify, isolate, and control the specific branches supplying the portion of liver to be removed, while meticulously preserving the vessels and ducts going to the future liver remnant. This is where recognizing those arterial variants is critical. A cholecystectomy, gallbladder removal, is usually performed at this stage to facilitate dissection and prevent future gallstone issues.
Okay, access, mobilization, hilar control, then the actual cutting.
Then comes the parenchymal division, the transection itself. Let's take a right hepatectomy as an example. After mobilizing the right lobe and controlling its inflow, right hepatic artery, right portal vein in the hilum, the surgeon identifies the planned transection plane, often along Cantley's line or slightly to the right of the middle hepatic vein, guided by intraoperative ultrasound. The liver capsule is scored, and then the parenchyma is divided using a combination of techniques, maybe crushing clamps, ultrasonic dissection, bipolar sealing devices, meticulously identifying and ligating or sealing small vessels and bile ducts as they are encountered. The large right hepatic duct is usually divided late in the transection. Finally, the right hepatic vein is identified as it enters the IBC and is divided, often using a vascular stapler.
And for the left side.
For a left hepatectomy, or left lateral segmentectomy, removing just segments 2 and 3, similar principles apply, but the dissection focuses on the left hilar structures, LHA, LPV, LHD, often found near the base of the round ligament umbilical fissure, and the left or middle hepatic veins. The transection plane is carefully chosen, again guided by ultrasound, often along the falciform ligament for a segmentectomy, or near the middle hepatic vein for a full left hepatectomy. Throughout these procedures, techniques to control bleeding are paramount. The Pringle maneuver, clamping the entire portal triad, is commonly used, often intermittently, for 15 minutes clamped, 5 minutes unclamped, to minimize ischemia reperfusion injury to the remnant liver. Some surgeons use selective hemihepatic vascular occlusion, clamping only the inflow to the side being resected. And ischemic preconditioning, a brief period of ischemia followed by reperfusion before the main clamping, has been shown to reduce liver injury, especially in fatty livers, possibly by preserving cellular energy stores. These techniques, combined with meticulous surgical technique, are what enable complex resections with acceptable safety.
It sounds like surgeons are doing everything possible to make the liver even more resilient before a big operation, especially if a large portion needs to be removed. How does preoperative portal vein embolization, PVE, fit into that strategy, essentially training the liver to grow before surgery?
That's an excellent way to put it, training the liver to grow. PVE is a crucial interventional radiology technique that leverages the liver's regenerative capacity to make major resections safer. It intentionally induces compensatory hypertrophy, or growth, of the future liver remnant, FLR, the part of the liver that will remain after surgery. It was developed after observing that when a tumor blocked a portal vein branch, the affected lobe shrank, atrophied, and the healthy lobe compensated by growing larger.
So how's it done?
PVE is performed percutaneously, usually via a transhepatic route under imaging guidance. An interventional radiologist accesses the portal vein system and selectively embolizes blocks off, often using coils or glue the portal vein branches, supplying the portion of the liver planned for resection. This blockage redirects nutrient-rich portal blood flow entirely to the intended FLR, providing a powerful stimulus for those segments to hypertrophy.
When is PVE considered?
It's considered when planning major resections, like a right trisectionectomy, removing segments 4, V, 6, 7, 8, or an extended right or left hepatectomy, where the calculated FLR volume based on preoperative CT or MRI scans is deemed too small to support the patient's metabolic needs postoperatively. Surgery is typically scheduled about 4 to 6 weeks after PVE to allow sufficient time for adequate hypertrophy, which is monitored with repeat imaging.
What's considered an adequate remnant size?
There's no universal rigid cutoff, but generally an FLR of 25–30% of the total estimated liver volume is considered adequate for a patient with an otherwise normal liver. However, the threshold is often raised for patients with underlying liver issues like steatosis, fatty liver, fibrosis, or those who have received extensive preoperative chemotherapy, as these factors can impair regeneration. In these cases, an FLR of 40% or even more might be targeted. PVE has been shown to reduce postoperative liver failure and mortality after major hepatectomy, significantly expanding the pool of patients eligible for potentially curative resection. PVE itself has a relatively low complication rate, mostly minor issues like transient pain or fever, though more serious complications like bleeding or non-target embolization can occur rarely.
For widespread or recurrent liver cancer, sometimes it's not a one-and-done surgery, is it? What are the advanced strategies, like stage resections or even repeat operations, for these more complex, challenging cases?
You're absolutely right, particularly for patients with initially unresectable metastatic liver tumors, often colorectal cancer with extensive bilobar disease, or those who develop recurrence after an initial resection. Multi-stage and repeat surgical strategies have become crucial components of modern liver surgery. One established strategy is two-stage hepatectomy. This is a planned, sequential resection strategy used typically for patients with multiple tumors spread across both lobes of the liver, where removing all tumors at once would leave an insufficient future liver remnant.
How does it work?
The first stage typically involves clearing all tumors from the planned future liver remnant, often the left hemiliver. This might involve wedge resections or segmentectomies. At the same time, the portal vein branch supplying the more diseased side, usually the right, is ligated or embolized, PVE, to induce hypertrophy of the cleaned FLR. After a period of weeks to allow for adequate hypertrophy, confirmed by imaging, the patient returns for the second stage. A major hepatectomy, for example, a right or extended right hepatectomy, to remove the remaining initially unresectable disease. This approach has yielded very good results for selected patients with colorectal liver metastases, significantly increasing the number considered resectable.
Is there a faster way to induce that growth?
Yes, a newer and more intensely debated technique is associating liver partition and portal vein ligation for staged hepatectomy, ALPTS. Described relatively recently in 2012, this technique also involved two stages. In the first stage, the surgeon performs portal vein ligation and an in situ transection of the liver parenchyma along the future resection line, essentially partitioning the liver but leaving the artery, bile duct, and hepatic vein to the part being removed temporarily intact. This complete partition seems to generate much more rapid and profound hypertrophy of the FLR compared to PVE alone, often allowing the second stage major hepatectomy to be performed much sooner, sometimes within 1–2 weeks.
Why is it debated?
While it achieves rapid hypertrophy, initial reports suggested significantly higher morbidity and mortality compared to traditional two-stage approaches or PVE alone. Technique refinements and better patient selection have improved results, but its exact role compared to PVE and standard two-stage hepatectomy is still being actively investigated and remains a hot topic among liver surgeons.
What about patients who have a recurrence after already having liver surgery?
For patients who develop recurrent liver cancer after a previous hepatectomy, particularly colorectal liver metastases confined to the liver, repeat hepatic resection is often a reasonable and potentially curative option, especially in experienced centers. Morbidity and mortality rates for repeat hepatectomy are generally low in experienced hands, though the surgery can be technically challenging due to adhesions from the prior operation. Survival rates after second or even third resections can be comparable to those after initial resections, although factors like the number and size of recurrent lesions and the disease-free interval between surgeries remain important prognostic indicators. Similarly, repeat hepatectomy has been performed for recurrent hepatocellular carcinoma, HCC, showing acceptable overall survival, though recurrence-free survival might be lower than after the initial surgery. Favorable prognostic factors include absence of portal vein invasion, a single HCC at the primary surgery, and a long disease-free interval. These advanced strategies really exemplify the continuous push in liver surgery to tackle increasingly complex scenarios.
Finally, the trend towards minimally invasive surgery has transformed many fields. How has it impacted liver surgery? And what are the benefits, especially with such a delicate and vascular organ where precision is everything?
Laparoscopic liver resection, or LLR, has indeed seen a significant expansion and maturation since its feasibility was first reported around the year 2000. While initially met with considerable apprehension due to the liver's vascularity, the challenges of bleeding control, and concerns about oncologic adequacy in a minimally invasive setting, great strides have been made through technological advancements and accumulating surgical experience. LLR now encompasses a wide spectrum of procedures, from relatively simple cyst unroofing or biopsy to non-anatomic wedge resections, formal anatomic segmentectomies, and even major hepatectomies like right or left lobectomies for malignancy. It's also being applied to living donor liver transplantation.
What techniques are used?
Pure laparoscopic approaches, using multiple small incisions for ports, and hand-assisted laparoscopic approaches are the most common. Robotic liver resection is also being increasingly utilized, offering potential advantages in dexterity and visualization for complex procedures. The hand-assisted approach, where the surgeon inserts one hand through a small incision while maintaining pneumoperitoneum, offers valuable tactile feedback, facilitates mobilization of the bulky liver, and can aid in rapid bleeding control if needed. It's often seen as a good bridge for surgeons transitioning to LLR or for more complex cases.
What are the proven benefits for patients?
When compared to traditional open hepatic resection, multiple studies and meta-analyses have consistently shown several benefits for LLR in selected patients. These include less intraoperative blood loss, decreased overall morbidity, fewer complications, reduced postoperative pain and narcotic requirements, faster return of bowel function, and significantly shorter hospital stays.
Shorter stays must have economic benefits too.
Yes. While laparoscopic procedures often involve higher costs for disposable instruments, cost-effectiveness analyses generally show LLR to be favorable overall, primarily due to the significant savings from shorter hospitalizations, often reduced by around 50%.
But the crucial question, are cancer outcomes compromised?
That was the major initial concern, but accumulating long-term data has been reassuring. For both HCC and colorectal liver metastases, multiple studies have now demonstrated that long-term oncologic outcomes, like overall survival and recurrence-free survival after LLR, are comparable to those achieved with open liver resection, provided that appropriate oncologic principles, adequate margins, etc., are strictly adhered to. This means patients can receive the significant short-term benefits of minimally invasive surgery without compromising their chances for long-term cancer control.
Is there a steep learning curve?
Yes, LLR, especially major hepatectomy, does have a significant learning curve, often reported to be around 60 cases or more, requiring specialized training and mentorship. Patient selection is also key, particularly during the initial learning phase. LLR has even been successfully applied to living donor hepatectomy for liver transplantation, initially for pediatric recipients, requiring a left lateral segmentectomy, and though still somewhat controversial and limited to highly experienced centers, now even for adult-to-adult right hepatectomy. So in summary, LLR performed by experienced surgeons in appropriately selected patients is a safe and beneficial option, offering clear patient advantages without compromising oncologic results. It represents a true paradigm shift in the field.
Wow, what an incredible deep dive into the liver. Seriously comprehensive. From those ancient myths about its amazing regenerative powers to the breathtaking precision of modern surgical techniques and our really nuanced molecular understanding, we've really covered so much ground today. You, our listener, have gained insights into its complex anatomy, its relentless physiological roles in keeping us alive, how doctors skillfully diagnose what goes wrong, and the cutting-edge treatments that are truly transforming lives. You really should have a professional level understanding of this vital organ now, knowing not just the facts, but why they matter.
Absolutely. If we connect this all back to the bigger picture, it's just so clear that the liver isn't just an isolated organ. It's this incredibly dynamic, resilient, and highly responsive system. It's constantly adapting, constantly signaling. Its profound connections to nearly every other system in the body make it a true frontier of ongoing discovery. From its unique ability to regenerate, which we're still trying to fully harness, to its intricate defense mechanisms and its central role in both health and disease, it's fascinating.
And this raises an important question for you, our listener, to think about. Knowing how adaptable and central the liver is to our health, what aspects of its care, or perhaps even its role in future therapies, do you think we'll see the most groundbreaking advancements in the next decade?
Yeah, consider the implications of, say, regenerative medicine, or those advanced molecular therapies targeting specific pathways we discussed today. How might they fundamentally change our approach to chronic liver disease or liver cancer? Will we see a future where personalized liver therapies based on molecular profiling are standard, or where regeneration is routinely induced to avoid transplantation altogether? What do you think?
That's a truly thought-provoking question, and definitely an exciting area to continue exploring on your own. Thank you so much for joining us on this deep dive into the liver. We hope you feel more informed, more curious, and definitely more confident in your mastery of this incredible organ. Until next time, keep digging deeper.